Welcome to the Deep Dive. We're here to give you that knowledge shortcut, especially if you're aiming for real mastery in your field.
That's right.
Today, we're taking a deep look, a really deep look, at a whole stack of clinical sources covering antenatal fetal well-being.
It's a crucial area.
Our mission here isn't just a quick summary. We want to equip you, the highly curious learner, with the kind of understanding elite professionals have the mechanisms, the exact criteria, the management implications.
And it's interesting how the focus has shifted over time, hasn't it? For so long, obstetrics was, well, overwhelmingly focused on maternal health, preventing maternal death.
Which has seen huge improvements, thankfully.
Incredible progress. Global maternal death rates have fallen significantly. But that success story means we now have, I guess you could say, a mandate to apply that same level of vigilance, perhaps even more, to the fetus inside the uterus.
And the need is stark. The sources we've reviewed are pretty clear. A huge majority, something like 80%, of fetal deaths actually happen before labor even starts, in the antepartum period.
That figure is staggering. And it really underscores why we monitor so closely. It's not routine ticking boxes. It's about preventing those losses.
So, to really grasp the objective avoiding fetal death, we need to understand what causes these losses in the first place.
Right. We can broadly group the major threats. First up, and it's a big one, around 35% are maternal complications.
Things affecting the mother directly.
Exactly. Chronic issues she might already have, like hypertension or problems that arise during pregnancy, severe preeclampsia, diabetes, maybe a serious infection. The mother's overall health is absolutely key.
So over a third of the risk stems directly from the maternal side. What's next?
The second major cause, accounting for about 30%, is chronic fetal hypoxia.
Lack of oxygen.
A persistent lack of oxygen, yes. And this is usually tied to the placenta not working properly, what we call placental insufficiency. Often this leads to intrauterine growth restriction, or IUGR.
So the baby isn't growing as expected because the supply line, the placenta, is failing.
That's the essence of it. The placenta just can't deliver enough oxygen and nutrients for the baby's needs.
Okay, so between maternal health issues and placental failure, that's already 65% of these antepartum deaths. What about problems with the fetus itself?
Those account for about 15%. This category includes congenital malformations, structural problems, and chromosomal abnormalities like Down syndrome.
16%. And the rest?
Well, that leaves the really difficult group. About 20% of these antepartum fetal deaths remain unexplained. Even with all our tests, we sometimes just don't find a clear cause.
That 20% is a huge challenge for research, definitely. But for clinical practice today, the goal is clear.
Absolutely. It's about preventing those known identifiable causes of death through really careful, continuous supervision of the fetus, coupled, of course, with excellent maternal care.
So how do we achieve that? What's the framework for this monitoring?
It's based on a structured system of antenatal fetal monitoring. And it really has two main aims. First, simply to make sure the baby is growing okay and seems generally well throughout the pregnancy.
Just tracking normal progress.
Right. And second, to actively screen for and identify any high-risk factors we know can negatively impact fetal growth or well-being.
Before we jump into the specific tests, there's a foundational concept in box 11.1 of our sources, the rationality of fetal tests. Why is this so important for someone aiming for mastery?
Because it grounds everything we do. It's about the ethics and the utility. You can't just run tests without justification. There are three key criteria any test must meet before we use it.
Okay, what's criteria number one?
The test has to give us information that's actually better, demonstrably superior to what we can figure out just by basic clinical evaluation, measuring the belly, listening to heart rate. If the simple stuff tells us enough, a fancy test might be redundant.
Makes sense. Avoid unnecessary testing. What's the second rule?
The results have to be genuinely helpful for management. They need to guide a clinical decision that actually leads to a better outcome for the baby or mother. Maybe it helps time the delivery better, or maybe it points towards an effective treatment we can give while the baby's still inside.
So the information has to be actionable and beneficial.
Exactly. And the third criterion really brings it home.
The risk-benefit balance.
Precisely. The benefits you get from the test information must clearly outweigh any potential risks. The test itself might pose risks to the mother, risks to the fetus, and also the costs involved. That risk-benefit ratio is the justification for using every single advanced tool we're going to talk about.
Okay, so we've established the why and the when for testing. Now, if a test does flag a fetus as being compromised, what are the options? What can the clinical team actually do?
There's a spectrum of actions, really, and it depends heavily on how severe the problem is and how far along the pregnancy is the gestational age.
So what's on the conservative end?
It might start with simple things, like recommending bed rest for the mother, often combined with stepping up the fetal surveillance, more frequent monitoring.
More checks, basically.
Yes. Then there might be specific drug therapies. A common one is giving corticosteroids to help mature the baby's lungs faster if we think delivery might be needed early.
And if things are more serious,
Then we move towards urgent delivery. That could be inducing labor or performing a C-section, either a term or, quite often, preterm. And critically, making sure the neonatal intensive care unit, the NICU team, is ready and waiting.
the sources also mention a very difficult scenario involving severe abnormalities.
Yes, and it's important to acknowledge. In cases where a severe fetal congenital anomaly is diagnosed, one that's incompatible with life or associated with extreme morbidity, termination of pregnancy is an option that needs to be available, guided by strict ethical frameworks and local laws, of course.
Okay, let's shift to the standard clinical evaluation, the timeline of care. It all begins with that very first visit, usually in the first trimester. Why is this initial assessment so critical?
It sets the stage for everything that follows. The absolute main goal of that first visit is to accurately estimate the duration of gestation, how many weeks pregnant the patient actually is.
Getting the dates right.
Exactly. We might use a bimanual pelvic exam initially, but nowadays an early ultrasound is much more reliable for measuring the fetus and confirming the dates. If our dating is wrong from the start, all our later assessments of growth and well-being will be inaccurate.
Makes sense. What else happens at that first visit?
It's also when we do a thorough maternal examination, identify any pre-existing risks, and start essential early investigations like blood tests and screening to protect the mother's health too.
All right, so the foundation is laid. Now, as the pregnancy progresses, what are we tracking in those subsequent visits to ensure things are proceeding satisfactorily? Let's start with maternal weight gain.
Okay. In the second half of pregnancy, so after about 20 weeks, we generally expect the mother to gain around 1 kilogram, maybe a couple of pounds, every 2 weeks. That's the average.
And deviations from that average are significant.
Very significant. Gaining weight too quickly, especially with swelling, could be an early sign of preeclampsia, that dangerous condition involving high blood pressure.
Okay.
But perhaps more concerning for the fetus is when weight gain slows down, stops altogether, or even reverses if the mother starts losing weight. That's a major red flag.
Why? What does that suggest?
It raises strong suspicion for intrauterine growth restriction, IUGR. It implies that the fetus isn't growing adequately and the overall maternal fetal unit isn't accumulating mass as it should. Something's likely wrong with the placental support.
Got it. Next key parameter, blood pressure. We know it's monitored constantly, but what's the specific importance of getting that early reading?
Getting a blood pressure reading before 12 weeks gestation is absolutely essential. That early measurement gives us the baseline.
Why is the baseline so important?
Because if the blood pressure goes up later in pregnancy, that baseline tells us whether we're dealing with chronic hypertension, high blood pressure the mother had before pregnancy, or if it's pregnancy-induced hypertension, something new that's developed.
And either way, hypertension is bad news for the fetus.
Either way, yes. Both chronic and pregnancy-induced hypertension can impair blood flow across the placenta, restricting oxygen and nutrients, and that significantly hampers fetal growth.
Okay, now for arguably the most common clinical screening tool for growth, measuring the fundal height. For someone aiming for that elite level, walk us through the precise procedure and the rule for interpreting it.
Right. It's simple but needs to be done correctly. You use a tape measure, starting from the very top edge of the pubic bone, the symphysis pubis, and measure up to the top of the uterus, the fundus.
Anything the patient needs to do.
Crucially, the patient's bladder must be empty. A full bladder can push the uterus up and give a falsely high reading.
Okay, bladder empty. Then what?
Then comes the rule of thumb, which really applies reliably after about 24 weeks gestation. The measurement in centimeters should roughly correspond to the number of weeks of gestation.
So at 30 weeks, you expect the measurement to be around 30 centimeters.
Exactly. There's a bit of acceptable variation, maybe plus or minus 1 or 2 centimeters, but it should track closely.
So this simple tape measure acts as an early warning system.
It's a very effective screening test for its simplicity. We plot the measurement on a standardized growth chart for pregnancy. if that measurement falls below the 10th centile for that specific week of gestation.
Meaning it's smaller than expected?
Right, significantly smaller.
Yeah.
That immediately triggers the need for more detailed investigations, usually an ultrasound to check fetal biometry, maybe Doppler flow studies, because we strongly suspect growth restriction.
Makes sense. What about assessing the amniotic fluid, the liquor, clinically?
During the abdominal palpation, the examiner gets a sense of the fluid volume. We're looking for extremes. Too much fluid, hydramnios, might suggest maternal diabetes or certain fetal anomalies.
But in terms of fetal compromise,
The bigger concern in the context of compromise, especially in the last trimester, is too little fluid oligohydramnios. Scanty liquor can be a key sign of placental insufficiency.
why is that?
Because if the fetus is chronically hypoxic, it starts shunting blood away from less vital organs, including the kidneys, to protect the brain and heart. Less blood flow to the kidneys means less urine production. And late in pregnancy, fetal urine is the main source of amniotic fluid. So low fluid often means the baby is stressed and not perfusing its kidneys well. It necessitates functional tests, like a biophysical profile or Doppler.
Okay. And one last clinical measurement, abdominal girth.
Yes, measuring the circumference of the abdomen, usually at the level of the umbilicus, is often done routinely in the last trimester. It provides another piece of the puzzle.
How so?
While it normally increases steadily, if we notice the abdominal girth is actually diminishing, especially in a high-risk patient, someone we already know has preeclampsia or IUGR, it's another clinical clue suggesting that placental function might be deteriorating further and the baby's nutritional state is worsening.
Okay, let's move from those routine clinical checks to the more specialized investigations. Can we quickly revisit the breakdown of fetal death causes, perhaps with a slightly refined focus for this context?
Sure, when we're thinking about what these special tests are targeting, the breakdown is roughly asphyxia, that lack of oxygen, still around 30%. Maternal complications, also about 30%.
Right.
Congenital malformations and chromosomal abnormalities, that's a solid 15%. Infection contributes, maybe 5%. And then we still have that persistent 20% that remain unexplained.
And that 15% due to congenital and chromosomal issues is a major focus of early pregnancy screening, isn't it?
Absolutely. The impact is huge. Think about this. Chromosomal abnormalities are found in something like 50%, half of all first trimester miscarriages.
Wow, that high.
Yes. And even among babies who are stillborn later in pregnancy, about 5% have a chromosomal defect. So early screening is fundamentally designed to detect these issues.
Can you break down the types of congenital abnormalities we screen for?
Certainly. There are basically four main categories. First, the chromosomal abnormalities themselves, problems with the number of chromosomes, like trisomy 21, which causes Down syndrome, or structural problems, like parts of chromosomes being rearranged or missing.
Okay, numerical or structural?
Second, single gene disorders. These follow predictable inheritance patterns like cystic fibrosis or sickle cell anemia.
One gene, one disorder.
Largely, yes. Third, we have polygenic or multifactorial disorders. These are more complex, involving multiple genes interacting with environmental factors. Neural tube defects, like spina bifida, fall into this category.
Genes plus environment.
Right. And fourth, there are teratogenic disorders. These are caused by exposure to harmful external agents during pregnancy, certain medications, infections like rubella, radiation, some chemicals.
So how do we screen for these, especially the chromosomal ones, early on?
It typically involves a combination of methods. Biochemical tests, like blood tests measuring specific hormones and proteins in the mother's blood.
Like the combined test.
Exactly. And biophysical methods, primarily specialized ultrasound scans like the neutral translucency scan, which looks at fluid at the back of the fetal neck. Sometimes cytogenetic methods are involved too.
And if that initial screening comes back positive, indicating a higher risk?
A positive screen doesn't mean the baby definitely have a problem. It just means the risk is elevated. So the next step offered is usually definitive diagnostic testing, like fetal karyotyping.
Which requires getting fetal cells?
Yes, typically through procedures like chorionic villus sampling, CVS, in the first trimester, or amniocentesis later on. These provide fetal cells to analyze the chromosomes directly.
This brings us right back to that risk-benefit calculation we discussed earlier. These tests aren't risk-free.
Not at all. That's the critical point. The screening tests themselves are generally safe, mainly blood draws and ultrasound. But the diagnostic tests, CVS and amniocentesis, carry a small but real risk of complications, including miscarriage. They're also more expensive and invasive.
So the justification has to be strong.
Absolutely. The potential benefit of knowing the diagnosis for planning, for management, for making informed decisions must clearly outweigh the risks and costs of getting that information. It's a constant balancing act in prenatal diagnostics.
Okay, shifting gears now to later in pregnancy, the second half onwards. We're moving into active surveillance. What are the main goals here, according to bodies like ACOG, the American College of Obstetricians and Gynecologists?
They frame it very clearly with two primary objectives. First, and most obviously, is to prevent fetal death.
The ultimate goal.
Right. But second, and this is crucial, is to avoid unnecessary interventions. We don't want to deliver babies prematurely or perform C-sections based on false alarms if the baby's actually doing fine.
A balancing act again. How do we achieve this surveillance?
We use a combination of clinical assessment, biochemical tests, and biophysical tests.
We'll get to biochemical tests for lung maturity later. Right?
Exactly. For ongoing surveillance of well-being, the main focus is on the biophysical methods. And all of these tests really are based on one single fundamental physiological principle.
Okay, let's nail this down. What's the core concept?
It's the fact that the fetal central nervous system, the CNS, is extremely sensitive to lack of oxygen.
To hypoxia.
Yes. When a fetus experiences ongoing chronic hypoxia, its metabolism shifts, leading to metabolic acidosis, a buildup of acid in the tissues. This acidosis directly depresses the CNS.
And that depression is something we can see.
We can observe its effects, yes. The depressed CNS leads to measurable changes in the fetus's biophysical activities, things like its movement, its muscle tone, the variability of its heart rate. We're essentially watching the physiological consequences of oxygen deprivation unfold.
So the simplest way to start looking for these changes is the fetal movement count, often called kick counts.
This is the cornerstone, the first-line screening test that the mother does herself. It's simple, costs nothing, and is widely used. We usually advise starting daily counts around 28 weeks.
And the principle behind it?
It's straightforward. A healthy, well-oxygenated baby moves regularly. If the baby starts experiencing significant hypoxia, the CNS gets depressed and the movements decrease noticeably. So a sustained drop in movements is a really sensitive early warning sign.
Are there specific ways women are told to count? The sources mention a couple of formulas. What's the Cardiff Count 10 method?
Right. The Cardiff method is based on a 12-hour window.
Yeah.
Patient starts counting movements from, say, 9 o'clock in the morning.
Yeah.
She just keeps track until she feels 10 distinct movements. Then she can stop counting for the day.
And when should she be concerned?
She needs to contact her provider immediately if either of two things happens. One, she counts fewer than 10 movements in the full 12 hours, and this happens on 2 consecutive days. Or two, if she perceives no movements at all for an entire 12-hour period in a single day.
Okay. What about the other method, the daily fetal movement count, or DFMC?
The DFMC is a bit more structured. It usually involves counting for a set period, often 1 hour, 3 times a day, maybe morning, midday, and evening.
And the threshold for concern there?
Generally, feeling fewer than 10 movements over a total of 12 hours, or specifically feeling fewer than 3 movements during any one of those dedicated 1-hour counting sessions, would be considered potentially abnormal and warrants investigation.
Can mothers reliably feel these movements?
Actually, yes. Studies show mothers perceive a very high percentage, around 88%, of the gross body movements that can be detected objectively using ultrasound or Doppler. They're good observers of their babies.
And the clinical significance if movements really do decrease or stop? It's urgent.
Extremely urgent. This is the most critical point about kick counts. A significant loss of perceived fetal movements is often followed by the loss of the fetal heart rate entirely within about 24 hours. It's a late sign of severe compromise, so there's no time to waste if a mother reports this. Immediate assessment is needed.
But are there reasons other than hypoxia why a mother might perceive fewer movements? Things that aren't necessarily dangerous?
Yes, absolutely, and that's important context. The most common reason is simply the fetal sleep cycle. Fetuses have quiet sleep states where they move very little. At term, they might spend about 25% of their time in this quiet state.
So the baby might just be asleep.
Could be. Other factors can also reduce the mother's perception. If the placenta is on the front wall of the uterus, anterior placenta, it can cushion the kicks. Too much amniotic fluid, hydramnios, can also make movements harder to feel. Maternal factors like obesity or taking certain medications like narcotics or sedatives can play a role. Even chronic smoking can potentially decrease fetal activity.
So a report of decreased movement needs assessment, but it doesn't automatically mean disaster.
Exactly. But hypoxia is the most serious cause, so you have to rule it out promptly.
Which brings us to the next step. The non-stress test, or NST. This uses cardiotocography, CTG, that belt monitoring fetal heart rate and contractions or movements. What's the specific principle of the NST?
The NST is looking for a specific physiological reflex, the link between fetal movement and a temporary increase in the fetal heart rate. In a healthy, well-oxygenated fetus with an intact, non-depressed CNS, when the baby moves, its heart rate should accelerate briefly.
So accelerations are good.
Accelerations linked to movement are the key sign of fetal well-being on an NST. That's why the test is considered valuable, primarily for identifying wellness, for reassuring us the baby is okay, rather than being great at diagnosing illness.
Okay, let's get precise for the mastery level. What defines a reactive NST result, the one we want to see?
A reactive NST, which is reassuring, requires seeing 2 or more fetal heart rate accelerations within a 20-minute observation period.
And how big do those accelerations need to be?
Each acceleration must peak at least 15 beats per minute above the baseline heart rate, and it needs to last for at least 15 seconds from start to return to baseline. 2 of those in 20 minutes makes it reactive.
And if you don't see that?
Then it's classified as non-reactive, which is non-reassuring and requires further investigation. It means that expected reactivity wasn't seen.
And statistically, this distinction matters hugely for risk assessment.
Immensely. A reactive NST is very comforting. The risk of fetal death within a week following a reactive NST is very low, around 5 per 1,000. But if the NST is non-reactive, that risk jumps significantly, maybe to around 40 per 1,000. That's why in high-risk pregnancies, like those with diabetes or IUGR NSTs, are often done frequently, maybe twice a week, starting around 32 weeks.
So here's the catch we often hear about. The NST has a notoriously high false positive rate, right? Meaning it's often non-reactive even when the baby is fine.
That's its major limitation, yes.
Yeah.
The false positive rate can be over 50%, sometimes even higher. Lots of healthy babies will have a non-reactive NST, maybe just because they're in a quiet sleep cycle during the test.
So if it flags healthy babies as potentially sick so often, why is it still such a cornerstone of surveillance?
Because of the flip side. Its false negative rate is very low, typically less than 1%.
Meaning, if the NST is reactive, we can be very confident the baby is okay, at least for the immediate future.
Exactly. It's excellent at confirming wellness. So it meets that ACOG goal of avoiding unnecessary intervention. We trust a reactive result. We accept the high false positive rate, the non-reactive results in healthy babies, because we know we have follow-up tests, like the biophysical profile, that are much better at distinguishing truly compromised babies from those who are just sleepy during the NST.
Is there anything done sometimes right after a non-reactive NST, maybe before launching into a full BPP?
Yes, often a vibroacoustic stimulation test, or VAS, is used.
Using sound or vibration on the mother's abdomen.
That's right. The idea is simply to wake the fetus up, to try and shift it from that quiet sleep state, non-REM sleep, into an active state, REM sleep. At term, babies spend maybe 70% of their time in active sleep, but that still leaves 25% in quiet sleep.
And if the NST becomes reactive after the VAS?
Then it's considered reassuring. The VAS helps reduce the false positive rate of the NST due to sleep cycles. It's a quick, harmless way to potentially avoid a more complex assessment if the baby was just napping.
Okay. Before we move to the BPP, let's quickly define what constitutes a truly normal cardiotocography CTG tracing overall, beyond just the reactive, non-reactive NST part, especially after 32 weeks.
Right. A reassuring CTG tracing needs several components. First, a stable baseline heart rate between 110 and 160 beats per minute.
The normal range.
Second, healthy baseline variability. The heart rate shouldn't be flat. It should fluctuate slightly. An amplitude of variability between 5 and 25 beats per minute is considered normal and reflects a healthy, responsive nervous system.
Variability is key.
Absolutely. Third, there should be no significant decelerations, especially late or variable decelerations. Maybe very short, shallow, early decelerations might be okay, but generally we want to see no concerning dips in heart rate.
And accelerations.
And as per the NST criteria, we want to see those accelerations, at least 2, in a 20-minute period, often associated with fetal movements. So good baseline, good variability, accelerations present, no significant decelerations. That's a reassuring picture.
The sources also briefly mention the contraction stress test, or CST. Although less common now, it was historically important. What was its purpose?
The CST was designed specifically to assess how the fetus handles the stress of uterine contractions, as a way of evaluating uteroplacental reserve, basically, how well the placenta is likely to cope during actual labor.
How'd it work?
Contractions were usually stimulated either with a very low dose of intravenous oxytocin or sometimes by nipple stimulation, and the fetal heart rate was monitored continuously.
What were they looking for?
The key was looking for late decelerations dips in the fetal heart rate that start after the peak of a contraction and recover slowly.
And what did late decelerations signify?
Late decelerations during a CST suggest the fetus doesn't have enough oxygen reserve to tolerate even the temporary reduction in placental blood flow caused by a contraction. It indicates uteroplacental insufficiency. A positive CST, meaning late decelerations were present with most contractions, was a strong indicator of fetal compromise and often led to delivery.
Why isn't it used much anymore?
Mainly because it's time-consuming, requires inducing contractions which carries some risk, and needs close supervision. The biophysical profile and Doppler ultrasound generally provide similar or better information about fetal status with less risk and hassle, but understanding the principle is still valuable.
Okay, so the NST has limitations. The CST is largely historical. That brings us to the fetal biophysical profile, the BPP. This uses real-time ultrasound and seems to be a much more comprehensive assessment.
It really is considered the gold standard for assessing current fetal status when there's concern. Its big advantage is that the score correlates very well with the baby's actual acid-base status, whether it's becoming acidotic due to hypoxia.
When is a BPP typically done?
The main indications are a non-reactive NST, or as primary surveillance in any pregnancy considered high risk for fetal compromise like known IUGR, poorly controlled diabetes, post-term pregnancy, decreased fetal movements.
How often is it performed?
If the initial test is normal in a high-risk patient, it's often repeated weekly. If a test result is abnormal or equivocal, the frequency usually increases to twice weekly, or even more often depending on the situation.
Let's get into the specifics. The Manning-modified BPP from 1992 is commonly used. It scores 5 parameters over 30 minutes, right? 2 points for normal, 0 for abnormal.
That's the system. 5 components, max score of 10.
Okay, component 1 is the non-stress test. We covered that. 2 points if it's reactive. This reflects acute oxygenation. What's the second parameter?
Second is fetal breathing movements. We need to see at least one episode of rhythmic fetal breathing movements lasting for more than 30 seconds within the 30-minute observation period to get 2 points.
Why are breathing movements so important?
Because these movements are controlled by higher centers in the fetal brain, and they are very sensitive to hypoxia. Often, fetal breathing movements are one of the first biophysical activities to disappear when the oxygen supply starts to dwindle. The fetus stops practicing breathing to conserve oxygen.
Interesting. Okay, what's the third parameter?
Third is gross body movements. This is looking for larger movements of the body or limbs. We need to see at least 3 discrete movements within the 30 minutes for 2 points.
Are these as sensitive as breathing movements?
Generally, no. Gross body movements require less complex CNS control, so they tend to persist longer than breathing movements when hypoxia sets in. They usually disappear later in the process of compromise.
All right, fourth parameter.
Fourth is fetal muscle tone. This requires seeing at least one episode of active extension of a limb or the trunk, followed by a rapid return to flexion. Even something simple like the fetus opening and closing its hand counts as demonstrating tone. 2 points if seen.
And where does tone fit in the sensitivity hierarchy?
Fetal tone is thought to be controlled by lower CNS centers and is generally the last of these acute biophysical variables to be lost before fetal death. Loss of tone suggests quite severe advanced hypoxia and acidemia.
Okay, so we have NST, breathing, gross movement, and tone. What's the fifth and final parameter?
The fifth one is different. It reflects more chronic status rather than acute. It's the amniotic fluid volume, AFV.
Assessing the fluid level, how is that scored?
To get 2 points, we need to find at least one pocket of amniotic fluid, measured vertically, that is at least 2 centimeters deep in 2 perpendicular planes. Basically a 2 centimeter by 2 centimeter pocket somewhere.
And low fluid points towards?
As we discussed earlier, low fluid oligohydramnios often reflects chronic placental insufficiency and reduced fetal urine output due to that blood flow redistribution away from the kidneys. So it's a marker of longer-term compromise.
So we get a score out of 10. How does that score translate directly into clinical management? This seems crucial for mastery. Let's start with a good score.
Right. A score of 8 out of 10, or 10 out of 10, is considered normal and reassuring. The risk of fetal asphyxia within the next week is very low. Management is usually expectant, continuing routine surveillance, maybe repeating the BPP weekly, or as clinically indicated.
What about a score of 6 out of 10?
A score of 6 is considered equivocal or suspicious for chronic asphyxia. Management here really depends on the gestational age.
How so?
If the pregnancy is mature, say 36 weeks or more, delivery is often recommended because the risks of continuing the pregnancy might outweigh the risks of delivery. But if the baby is preterm, especially if lung maturity tests like the LS ratio are unfavorable, less than 2.0,
Oh, lungs aren't ready.
exactly, then the decision is tougher. Often, the DPP might be repeated in 4 to 6 hours, maybe after giving the mother hydration or changing her position, to see if the score improves. You're balancing the suspected fetal risk against the definite risks of prematurity.
Okay, what if the score drops lower to 4 out of 10?
A score of 4 is highly suspicious of chronic asphyxia. Again, if the pregnancy is mature, 36 weeks or more, the recommendation is usually delivery. If significantly preterm, say less than 32 weeks, the situation is serious. Management might involve intensive monitoring, possibly giving steroids for lung maturity and planning for delivery soon, maybe repeating the test in 4 to 6 hours while preparing, but the threshold for intervention is much lower.
And the lowest scores, 0 or 2 out of 10.
This strongly suggests acute fetal asphyxia and imminent danger. The protocol usually involves observing for up to 120 minutes to ensure it's not a transient finding. But if the score persistently remains 4 or less, delivery is indicated urgently regardless of the gestational age. The risk of fetal death is considered too high to wait.
And the confidence in these scores is high.
Very high, especially at the reassuring end. The false negative rate for a normal BPP, a score of 8 or 10, is extremely low, less than 1 per 1,000 or 0.1%. If the BPP is normal, the baby is very likely okay for now.
Now, sometimes a quicker version is used, the modified biophysical profile. What does that involve?
The modified BPP aims for efficiency. It combines just 2 components, the non-stress test, NST, and an ultrasound assessment of the amniotic fluid index, AFI.
What's the AFI?
The AFI is a quantitative measure of fluid volume. The uterus is divided into 4 quadrants, and the deepest vertical pocket of fluid is measured in each quadrant. The AFI is the sum of these 4 measurements in centimeters.
How is the modified BPP interpreted?
It's considered abnormal or non-reassuring if either the NST is non-reactive or the AFI is low, typically defined as less than 5 centimeters.
What are the pros and cons compared to the full BPT?
The main pro is speed. It takes less time. It's quite good at predicting fetal compromise. However, the full BPP generally has a lower false positive rate. It's less likely to flag a healthy baby as potentially sick compared to the modified BPP or the NST alone. The full BPP gives a more nuanced picture of fetal physiology.
Beyond the BPP, basic ultrasonography for biometry remains crucial, especially for diagnosing intrauterine growth restriction, IUGR. You mentioned serial measurements. Which specific measurement is most reflective of fetal nutrition?
The single best measurement for assessing current fetal size and nutrition is the abdominal circumference, AC.
Why the abdomen?
Because the size of the fetal abdomen is largely determined by the size of the liver, which stores glycogen, and the amount of subcutaneous fat. Both of these are directly affected by nutritional supply via the placenta. When nutrition is restricted, the liver shrinks, fat deposition decreases, and the AC measurement lags behind other parameters like head circumference or femur length.
And you mentioned the ratio of head circumference, HSC, to abdominal circumference, AC, earlier. How does that help?
Right, the HCSE ratio helps differentiate the type of growth restriction. Normally, the AC grows faster than the HC in the latter part of pregnancy, so the HCSE ratio decreases. If we see an elevated HCSE ratio, greater than 1.0, after about 34 weeks, it suggests asymmetrical IUGR.
What does asymmetrical mean here?
It means the head growth is relatively preserved while the abdominal growth is restricted. This is the classic pattern seen with late-onset placental insufficiency. The fetus sacrifices body growth to maintain blood flow and oxygen delivery to the vital organs, especially the brain. This is the brain-sparing effect.
And if the ratio is normal, but both measurements are small?
If both HC and AC are proportionally small, keeping the ratio near normal, it suggests symmetrical IUGR. This often implies a problem that started much earlier in pregnancy, affecting overall cell multiplication, possibly a chromosomal abnormality, an early infection, or significant maternal constitutional factors.
Let's revisit amniotic fluid volume, AFV, one more time. We know low fluid oligohydramnios is bad, linked to hypoxia. Can you detail that physiological link again?
Sure. The main determinants of amniotic fluid volume in the second half of pregnancy are fetal urine production and fetal swallowing, plus some contribution from lung fluid. When the fetus experiences chronic hypoxia, the brain-sparing reflex kicks in.
Shunting blood to the brain.
Yes, and away from other areas, including the kidneys. Blood flow to the fetal kidneys decreases due to vasoconstriction. Less blood flow means the kidneys produce less urine. Since fetal urine is the primary source of amniotic fluid late in pregnancy, decreased urine output directly leads to oligohydramnios.
Which is why the AFI measurement is so important.
Exactly. Measuring the AFI, summing those four-quadrant pockets, gives us a quantitative handle on this. An AFI less than 5 centimeters is generally considered oligohydramnios and is clearly associated with increased perinatal risks because it often reflects that underlying fetal hypoxemia and placental insufficiency. A normal deepest vertical pocket should be more than 2 centimeters.
Okay, now we move into arguably the most sophisticated layer of assessment, Doppler ultrasound velocimetry. This isn't just looking at structures, it's measuring blood flow dynamics.
That's right. Doppler gives us real-time information about blood flow speed and resistance in specific fetal and placental vessels. This tells us about downstream vascular resistance, how easy or hard it is for blood to flow through, and it can also give us clues about fetal cardiac function.
Where do we typically look first?
The workhorse is arterial Doppler, specifically looking at the umbilical artery, UA. This vessel reflects the state of the placental circulation.
What are we measuring in the umbilical artery?
We're looking at the waveform of blood flow over the cardiac cycle. We measure the peak speed during systole, when the heart pumps, that's S, and the speed during diastole when the heart refills, that's D. We also look at the mean flow velocity, M.
And from S and D, we calculate indices.
Correct. Several indices are used to quantify resistance. The simplest is the SD ratio, S divided by D. Others include the pulsatility index, or PI, calculated as S minus D divided by the mean velocity M, and the resistance index, or RI, S minus D divided by S. They all essentially measure the same thing, the impedance to flow.
How should these indices change normally during pregnancy?
In a healthy pregnancy, as the placenta grows and its vascular network expands massively, the resistance to blood flow decreases. This means more blood flows easily during diastole. So normally, the SD ratio, PI, and RI should all decrease as gestation advances.
So high values are bad.
Exactly. If we find values that are abnormally high for the gestational age, say more than 2 standard deviations above the mean, it tells us there's increased resistance in the placental vascular bed. Diastolic flow is reduced. This is a key sign of placental dysfunction and is strongly associated with risks like IUGR and preeclampsia.
And what happens in severe cases? What are the really critical Doppler findings in the umbilical artery?
The most concerning findings are absent end diastolic velocity, AEDV, meaning there's no forward blood flow during diastole, or even worse, reversed end diastolic velocity, REDV, where the blood flow actually reverses direction back towards the fetus during diastole.
What does that mean physiologically? Figure 11.2 in sources refers to this.
Pathophysiologically, AEDV, and especially REDV, indicate extremely high resistance in the placental circulation, suggesting a severe failure of the normal development of the placental blood vessels specifically, a failure of trophoblast invasion into the uterine spiral arteries. The downstream resistance is so high that forward flow halts or reverses when the heart relaxes. These findings are ominous, associated with a very high risk of perinatal mortality and morbidity, often indicating severe fetal hypoxia and acidemia.
Okay, that covers the umbilical artery, reflecting the placenta.
Mm-hmm.
What about Doppler and other vessels? You mentioned venous Doppler.
Yes, looking at fetal veins like the ductus venosus, DV, or even the umbilical vein, UV, gives us insights into the fetal cardiac side of things, how the heart is coping with the load.
How does that work? What are we looking for?
It's about cardiac forward function, the heart's ability to handle the blood returning to it, compliance, its bumping strength, contractility, and the resistance it pumps against afterload. Normally, blood flow in the umbilical vein should be smooth and continuous, or monophasic.
And in a compromised fetus.
In fetuses with deteriorating cardiac function, often due to chronic hypoxia and increasing workload, we might start seeing pulsatil flow in the umbilical vein.
Why pulsatil?
It reflects increased pressure in the fetal right atrium, increased central venous pressure, or CVP. The failing or overloaded heart can't easily accept the venous return, so the pressure fluctuations from the heartbeat are transmitted backwards into the umbilical vein, disrupting that normally smooth flow.
What about the ductus venosus?
The ductus venosus is a shunt bypassing the fetal liver. Abnormal Doppler flow patterns here, particularly absent or reversed flow during atrial contraction, the A wave, are very significant. They indicate high atrial pressure and poor cardiac compliance, and are strongly linked to impending fetal acidemia and increased risk of stillbirth. These venous changes often represent a pre-terminal state.
Let's try to synthesize this. Table 11.3 in the sources likely summarizes the significance across vessels. Can you walk us through that?
Okay, thinking about the key vessels. In the umbilical artery, UA, reduced, absent, or reversed diastolic flow tells us about placental failure, that failed trophoblast invasion leading to increased resistance, causing IUGR and preeclampsia risk. It reflects the placental side of the problem.
Right, then the MCA.
In the middle cerebral artery, MCA, we look for signs of adaptation. Increased diastolic flow leading to a decreased SD ratio, or PI, indicates vasodilation in the fetal brain. This is the brain-sparing effect, the fetus diverting oxygenated blood preferentially to the brain in response to systemic hypoxemia. It's a compensatory mechanism.
And finally, the venous side.
In the ductus venosus, DV, and umbilical vein, UV, abnormal flow patterns like pulsatility in the UV or absent reversed A wave in the DV tell us about cardiac compromise. Increased CVP, decreased cardiac compliance. This suggests the fetus's compensatory mechanisms are failing, leading towards heart failure and acidemia. It's often a latent ominous sign.
So combining the anatomical information from standard ultrasound with these dynamic flow patterns from Doppler gives a really powerful picture.
Absolutely. This combination has been a game changer. It allows for much more precise assessment of fetal status, helping us intervene when necessary, but also, crucially, avoid unnecessary premature deliveries when the Doppler studies are reassuring, significantly reducing perinatal mortality and morbidity.
We've covered surveillance extensively. Now let's turn to the final piece, assessing fetal pulmonary maturity. This becomes critical when delivery is being considered, especially preterm delivery.
That's exactly right. While amniocentesis in late pregnancy can also be used to assess the severity of Rh isoimmunization by measuring bilirubin, its most common use today is to determine if the fetal lungs are mature enough to function adequately outside the womb.
Why is this so vital?
Because the biggest risk for babies born prematurely, especially before 37 weeks, is respiratory distress syndrome, or RDS.
Caused by a lack of surfactant.
Precisely. Pulmonary surfactant is a substance produced by specialized cells in the lungs, the type 2 alveolar cells. It reduces surface tension inside the tiny air sacs, the alveoli, preventing them from collapsing when the baby exhales. Without enough surfactant, the lungs are stiff, breathing is incredibly difficult, and the baby develops RDS.
And we can measure surfactant components in the amniotic fluid.
Yes, the surfactant is packaged into structures called lamellar bodies inside the type 2 cells. These are released into the alveolar space, mixed with fetal lung fluid, and this fluid eventually gets expelled into the amniotic cavity. So, by sampling the amniotic fluid via amniocentesis, done under ultrasound guidance for safety, we can measure surfactant or its components.
For someone aiming for mastery, knowing the different tests for this is key. The sources list quite a few. Let's start with the classic, the lecithin-sphingomyelin, or LS ratio.
The LS ratio was the historical gold standard. It relies on the fact that lecithin, specifically phosphatidylcholine, is the main functional component of surfactant, and its concentration in amniotic fluid rises sharply after about 34-35 weeks. Sphingomyelin, another lipid, remains relatively constant.
So you compare the two.
Exactly. Early in the third trimester, the ratio might be 1-to-1. As the lungs mature, lecithin increases, and the ratio climbs. The key threshold is an LS ratio greater than 2. This generally indicates that the risk of RDS is low. The lungs are considered mature.
Are there quicker, maybe bedside tests?
Yes, the shake test, also known as the bubble test or Clemens test. This is a rapid, qualitative test based on surfactant's ability to form stable bubbles in the presence of ethanol.
How does it work?
You mix amniotic fluid with 96% ethanol in a test tube, shake it vigorously, and let it sit. If enough surfactant is present, it creates a stable ring of bubbles at the surface that persists for at least 15 minutes. It's a simple pass-fail indicator.
Is there a more quantitative version of that?
Yes, the Phone Stability Index, FSI. This essentially quantifies the shake test principle using serial dilutions of the amniotic fluid with ethanol. The result is reported as an index number. An FSI greater than 47 is considered highly predictive of lung maturity and virtually excludes the risk of RDS.
What about looking for specific components other than just lecithin?
Phosphatidylglycerol, PG, is another important phospholipid component of surfactant. It appears slightly later in gestation than the rise in lecithin, typically around 35-36 weeks. Its presence, usually detected by thin-layer chromatography, is a very reliable sign of advanced lung maturation. Even if the LS ratio is borderline, the presence of PG is highly reassuring.
Are there direct quantitative measures of surfactant components?
Yes. One is measuring saturated phosphatidylcholine, SPC, the most active form of lecithin. A level of 500 nanograms per milliliter or greater is indicative of maturity. Another method is fluorescence polarization. This technique uses polarized light to measure the ratio of surfactant, which affects polarization, to albumin, which doesn't, in the amniotic fluid. A result of 55 milligrams of surfactant per gram of albumin or higher indicates lung maturity.
What about simpler optical measurements?
One is measuring the amniotic fluid optical density, OD, at a specific wavelength, 650 nanometers. As surfactant components in vernix accumulate, the fluid becomes more turbid, increasing its optical density. An OD 650 greater than 0.15 generally correlates with lung maturity.
And you mentioned lamellar bodies earlier. Can we count those directly?
Yes, and this has become a very popular method because it's fast and can often be done using standard automated hematology counters found in most hospital labs.
Why hematology counters?
Because lamellar bodies happen to be roughly the same size as platelets, so the machine can count them in the amniotic fluid sample just like it counts platelets in blood. A lamellar body count, LBC, greater than 30,000 per microliter is generally considered indicative of pulmonary maturity. Some labs use slightly different thresholds, but that's a common one.
Okay, almost there. What were the older, perhaps less common now, cytological or visual assessments?
One was looking at orange-colored cells. You'd stain amniotic fluid cells with Nile blue sulfate. Cells shed from the fetal sebaceous glands contain lipid and stain orange. The theory was that a higher percentage of orange cells, say 50%, indicated more mature fetal skin with vernix production, which correlated roughly with lung maturity. It's not very precise, though. And the simplest observation is just amniotic fluid turbidity. Early in pregnancy, the fluid is clear. As the fetus matures, shed skin cells and vernix caseosa make the fluid increasingly cloudy or turbid. Markedly turbid fluid suggests term maturity, but it's very subjective.
That's a comprehensive list. 10 different ways to assess lung maturity. And briefly, you mentioned amniocentesis is also used for Rh isoimmunization.
Yes, in cases where the mother is Rh negative and has developed antibodies against Rh positive fetal red blood cells, amniocentesis can be used to measure the level of bilirubin in the amniotic fluid.
How does bilirubin get there?
When the mother's antibodies destroy fetal red blood cells, hemolysis, bilirubin is released. It gets into the amniotic fluid. By measuring the optical density difference at a wavelength of 450 nanometers using spectrophotometry, we can estimate the amount of bilirubin, which directly reflects the severity of the fetal hemolysis and anemia. This helps guide management, like deciding if the baby needs an intrauterine blood transfusion or needs to be delittered.
Wow. Okay, that was truly a deep dive. We've covered a massive amount of ground, really aiming for that complete mastery of antenatal fetal well-being.
We really have. It's complex but logical when you break it down.
We started right at the beginning, confronting that stark statistic, 80% of fetal deaths happening before labor, and grounding everything in the principle that any test we use has to be justified, offering real benefit that outweighs the risk.
That rationality is key. Then we move through the clinical assessment, the importance of accurate dating, tracking weight gain, blood pressure, and particularly that fundal height measurement as the essential first-line screen for growth issues.
And we established the core physiological concept underpinning almost all the biophysical tests. The fetus's central nervous system is highly sensitive to hypoxia, and this leads to observable changes.
Exactly. From the decrease in fetal movements felt by the mother, the kick count being that vital initial signal which then triggers
the non-stress test. We acknowledged its limitations, that high false positive rate, but valued its very low false negative rate for confirming wellness. And when the NST is non-reactive, we move to the more definitive assessment.
the biophysical profile. We detail the 5 components: NST, breathing, movement, tone, and fluid volume, and how the score directly guides management based on the level of suspected asphyxia. Its high predictive value is crucial.
Then we layered on the sophistication of Doppler ultrasound, understanding how flow changes in the umbilical artery, especially absent or reversed end diastolic flow, signal that critical increase in placental resistance.
And contrasting that with the brain sparing, seen as vasodilation of the middle cerebral artery, and the late signs of cardiac strain seen in the ductus venosus and umbilical vein, Doppler paints a dynamic picture of fetal status and adaptation.
Finally, we cataloged that extensive list of tests for fetal pulmonary maturity, essential knowledge for timing delivery safely when intervention is needed. From the classic LS ratio needing to be over 2, to the presence of PG, to the rapid lamellar body count needing to be over 30,000.
It all ties together. Every score, every index, every clinical sign ultimately relates back to assessing the oxygenation and neurological integrity of the fetus using the best tools available.
So here's the final provocative thought we want to leave you with. We established early on that even with all this sophisticated monitoring, about 20% of fetal deaths remain completely unexplained. Given the incredible detail, we can measure subtle changes in heart rate variability, blood flow redistribution, intricate biophysical activities. What fundamental biological process, something perhaps we can't yet measure easily in utero, do you think might hold the key to unlocking that final mysterious 20%? Could it be related to cellular energy production, maybe mitochondrial function, or perhaps subtle inflammatory or immunological processes at the maternal-fetal interface? Something for you to ponder.
Definitely food for thought.
Yeah.
Until our next deep dive.